All right. Can everyone hear me okay? Good? All right. Today I'll be speaking about parental anticoagulation reversal. I have no obligations to disclose. The objectives for today's seminar are to review pharmacokinetic considerations with current anticoagulant reversal agents, to examine proposed immunogenic mechanisms for protamine sulfate adverse reactions, to evaluate the evidence regarding different strategies for managing fondaparinux-associated bleeds, and then to discuss various anticoagulation options, reversal options currently being developed. The parental anticoagulants that I'll be focusing on today include the antithrombin-based anticoagulants, so unfractionated heparin, low molecular weight heparins, and then fondaparinux. So unfractionated heparin is a glycosaminoglycan chain with an active pentasaccharide sequence. This sequence binds to antithrombin, inducing a conformation change that allows antithrombin to bind to both factor 10A as well as form a charge-dependent complex with thrombin. So while heparin also inactivates factors 9, 11, and 12 on the intrinsic clotting cascade. So heparin is primarily cleared through two pathways. The first pathway is saturable, therefore submitting heparin to first-order kinetics, and that pathway is through heparin binding to endothelial cells and macrophages, leading to it being internalized and polymerized. So at most therapeutic doses, this is how heparin is cleared, which is why we tend to not think of it as a renally cleared medication. However, when this pathway is saturated, heparin then undergoes renal clearance, and so at higher bolus doses, we can see heparin start to have increasingly prolonged half-lives. The main agent that we think of for heparin reversal is protamine sulfate. Due to the relatively short half-lives of heparin, there aren't many situations in which we need to actively reverse it. Most times we can simply just stop the drip. Some situations in which you would use protamine sulfate would be emergent reversal prior to or during surgery, for use in cardiopulmonary bypass, as well as in the setting of intracerebral hemorrhage. So protamine itself is a basic protein largely composed of arginine that's derived from fish sperm, specifically from salmon species. And this basic positively charged protamine interacts with the negatively acidic heparin, specifically the sulfate content of heparin. And through the ionic interactions between the two, it forms an inactive stable complex. And these ionic attractions between the protamine and heparin are strong enough to overcome the attraction between heparin and antithrombin itself, leading to increased dissociation of heparin, and this free heparin then becomes neutralized. Protamine is typically dosed at a ratio of 1 milligram per 100 units of heparin, and then considering the second part, the time component. So it's dosed for the heparin received in the past 2 to 3 hours, which is based off of a half-life of 60 or 90 minutes. So 2 half-lives is the duration that we're considering. And the maximum dose of protamine that may be administered is 50 milligrams. So with protamine, it's typically given as an IV infusion over at least 10 minutes, followed by monitoring with an APTT drawn at 5 minutes. And so protamine itself has a half-life of about 5 to 7 minutes. So that 5-minute APTT allows us to get a baseline sort of assessment of the reversal of the heparin. You may see recommendations for getting a repeat APTT anywhere from 2 to 8 hours afterwards. However, when you consider the short half-life of heparin, at that point, most of the heparin will have been cleared by the body, and therefore it can create sort of a potential confounding variable in your assessment. If you see an APTT that's still prolonged at that point, it may be an underlying coagulopathy, it may be liver failure, or it could be a hypercoagulable state such as APS. So with protamine, there's 3 main types of administration reactions that we typically see. The first one, type 1, is a transient hypotension. And this occurred in about 10% of our cardiopulmonary bypass patients, with about 2% of patients having a precipitous drop in blood pressure. The second type is type 2, so it includes both IgE-mediated and anaphylactoid reactions. And the type 3 and third and final category is a non-cardiogenic pulmonary edema, which results in right ventricle dysfunction, followed by subsequent left ventricle underfilling, which can lead to systemic hypotension and ultimately vascular collapse. This reaction has a high associated mortality of about 30%. And the only predictive factor seen with this reaction is that in about 80% of those cases, patients had had prior exposure to protamine. So the overall risk factors for having a protamine adverse reaction includes diabetic patients that have received insulin NPH or neutral protamine hagedron, male patients that have vasectomy, or patients that have fish allergy or sensitivity. Some of the countermeasures that can be seen for adverse reactions include rate of administration, which is the main one identified in the literature. The recommended rate for that is less than 5 milligrams per minute. Here at UVA, we used a fixed duration of 15 minutes, so that even with that maximum dose of 50 milligrams, it'd still be administered about a third of the rate slower than what's recommended. For planned protamine administrations, for say with your cardiopulmonary bypass patients that might have had previous exposure to protamine, you could pre-medicate them with steroids and antihistamines. However, pre-medication should never delay the administration of protamine itself. And finally, due to that type 3 reaction, there is a need to have immediate access to advanced airway equipment in case of resuscitation. However, when you consider when protamine would mostly be administered, ED, ICU setting, or an OR, there is going to be readily available access. So while the IgE antibodies were implicated in the type 2 reactions, we found that with protamine, there's actually two other classes of antibodies that are created, both of them IgG. The first one is IgG antibodies formed against protamine by itself. And then the second category that we're more concerned about are antibodies formed against the protamine heparin complex. And so of those protamine heparin antibodies, about 15.6% of them have actually been shown to activate platelets through the Fc gamma receptor 2A mechanism, which is the exact same mechanism that's subsequently used for HIT. And then of the patients that tested positive for the protamine heparin antibodies, about 60% of them also tested positive for the anti-PF4 heparin antibody that's implicated in HIT. Over here on the chart on the right, we can see that at baseline, there's relatively low rates of these antibodies, particularly the protamine alone. However, following exposure to protamine after a cardiopulmonary bypass, we can see this rate increase roughly about fourfold. However, following this rise in antibodies amongst our patients, we then see the amount of patients that test positive trail off, and then at about 4 months later, it's roughly about back to that baseline rate. So while protamine has the potential to create protamine-induced thrombocytopenia, when compared to heparin-induced thrombocytopenia, there's several similarities between the two. They both form a multimolecular complex. They both have similar immunization triggers, the administration of heparin as well as heparin reversal for cardiac surgery. However, with protamine-induced thrombocytopenia, there's also potential immunization with medical patients receiving low molecular weight heparins and protamine insulin. They both use the same method of platelet activation, and both antibodies are transient. The main difference between the two conditions is that with HIT, we tend to think of that classic presentation of the thrombocytopenia at 5 to 10 days. However, with protamine-induced thrombocytopenia, we see it much earlier after surgery, roughly peaking at around day 2 or day 3. So one of the main studies out there looking at protamine-induced thrombocytopenia showed that there was no significant difference between patients that had no antibodies or patients that tested positive for antibodies unless they were platelet activating. But there was a significant difference with those platelet activating patients. They were seen to be at increased risk of developing a thrombocytopenia, as well as when they did develop a thrombocytopenia, it would be more severe as well as prolonged. With those patients, they tended to have about a 25% reduction in platelet production. So we can see that drop at about day 2 or day 3, followed by a slower rise in activity over the next few days. However, with protamine-induced thrombocytopenia, it does resolve naturally by itself. And then those patients that had the activating antibodies were also shown to be an increased risk of having early arterial conclusions. So of the 7 patients with those activating antibodies, 2 of them had events, one being an early coronary occlusion, the other one being a stroke, both of them roughly around day 2 or day 3. And then after adjustment, the odds ratio between patients with activating antibodies and those without was roughly around 22. However, due to the small number of patients that have been studied, roughly about 600, more outcomes-based research is needed to determine what the actual effect is of these thrombocytopenias and whether there is an increased thrombosis risk with this disease. When you look at the scoring tools available for HIT for cardiopulmonary bypass patients, there's no direct mention of protamine. However, based on the time component question of presentation of the thrombocytopenia, there is some influence there where the early presentation weighs negatively in determining your HIT score. And then finally, with these patients, they did see with the activating antibodies that patients ended up needing significantly higher protamine requirements. However, they are relatively similar. And more research would be needed to determine what the implications are with regards to dosing. This brings us to our first assessment question. A 50-year-old male with a sulfa allergy is undergoing cardiac surgery with heparin for cardiopulmonary bypass. Following protamine administration, his platelet count abruptly dropped from 88 to 26. All heparin orders were discontinued, he was started on argatroban, and a HIT panel was ordered. Which of the following factors would make you suspect protamine instead of heparin as the more likely cause for the thrombocytopenia? Any volunteers? Yep, B, timing of the thrombocytopenia. So while protamine is largely used for unfractionated heparin reversal, it can also be used for low molecular weight heparin reversal. The low molecular weight heparins tend to have shorter chains than unfractionated heparin, leading to greater anti-10A inhibition rather than thrombin, as they're unable to form that charge-dependent complex. The low molecular weight heparins also have less cellular and protein binding compared to unfractionated heparin, leading to lower rates of HIT, as it's generally less immunogenic. And then because it also interacts less with cells, there's less reliance upon that saturable pathway, leading to greater renal clearance, which gives us longer half-lives and twice-a-day administration. So with neutralizing low molecular weight heparins, we see a reduced effect compared to unfractionated heparin. And this is largely believed to be due to reduced sulfate charge densities on the low molecular weight heparin molecules itself. And these reduced sulfate contents have been strongly tied to reduction in anti-10A neutralization. And based upon the specific sulfate content of each low molecular weight heparin, there's increasing efficacy of neutralization. So even with tenazaparin, which is the most neutralizable low molecular weight heparin, we still see that the anti-2A neutralization is about 99%, but then the anti-10A is only about 40%. And so due to this partial anti-10A neutralization activity, we might see only partial reversal of a bleed. So dosing of protamine for low molecular weight heparins is a little more complex than the unfractionated heparins, as the time component of since last administration is able to affect the dosing ratio used for calculating our dose. So when our low molecular weight heparin's been administered less than 8 hours, use a 1 milligram to 1 milligram ratio if it's enoxaparin, or 100 anti-10A units for the other low molecular weight heparins. When administration is 8 to 12 hours, we drop to a reduced ratio of 0.5 to 1. However, once it's been after 12 hours due to variations in clearance of the low molecular weight heparins, is more difficult to predict what dosing should be and what the remaining content of the low molecular weight heparin is, so it's therefore not recommended. And sort of similar conditions are why protamine administration is not recommended for reversal of prophylactic doses of low molecular weight heparins in the setting of ICH. It's again that unsurety about what actually is entered the system and what still remains. Our second assessment question: a 6-year-old male arrives at UVA-ED at 2000 with altered mental status. His wife reports that he recently underwent a right TKA and is on enoxaparin 80 BID for DVT treatment. She states that he injected his enoxaparin at 10 o'clock that morning, and the ED resident asks you for help dosing protamine for reversal. What protamine dose should you order? Yep, it's be 40 milligrams. So because it was administered 10 hours ago, we use the 0.5 ratio, and 80 times 0.5 is 40 milligrams, correct? So while protamine can be used for reversal of unfractionated heparin and possible reversal of low molecular weight heparins, it's overall very much an imperfect agent. There's the high rate of administration reactions, there's the potential for immunogenic thrombocytopenias, there's a paradoxical anticoagulant effect that can be seen with protamine overdose, which is why we need to be so careful when dosing patients. And then there's also potential for incomplete reversal of the low molecular weight heparins through reduction of anti-10A neutralization. The third anticoagulant we'll be talking about today is fondaparinux. Fondaparinux is comprised only of that pentasaccharide sequence, so therefore it's only able to act on factor 10A. It's even more renally cleared than low molecular weight heparins, leading to increased half-lives of 17 to 21 hours, and therefore we're able to do QD dosing with it. So fondaparinux is an indirect inhibitor of anti-10A, and it prevents formation of the prothrombinase complex with factor V, which causes indirect thrombin inhibition. However, with fondaparinux, there's also additional antifibrinolytic activity. And so based off of that indirect thrombin inhibition, we can see issues with fibrin formation and subsequent issues with fibrinolytic activity, as seen here, where the reduction of thrombin causes decreased formation of a thrombin-thrombomodulin complex, which leads to reduced activation of TAFI, or thrombin-activated factor inhibition. This leads to increased plasmin and increased fibrinolysis. The clots that are formed are more porous and more susceptible to endogenous TPA. The first strategy that was evaluated for reversal of fondaparinux was NOVA7, as protamine is completely ineffective with reversing it. The first study used plasma taken from 16 volunteers, healthy volunteers, and these patients were given either fondaparinux, recombinant factor VII, to see what the effects of each were, as well as a combination of both to look at reversal. And the theory behind this is that the activated factor VII will drive forward activation of factor X and overcome the factor X inhibition, leading to increased formation of the prothrombinase complex, and therefore driving forward the rest of the clotting cascade. So looking at some of the thrombin generation studies that are typically seen in our anticoag studies, we can see that over here on the left, when fondaparinux is administered, it roughly doubled the thrombin generation time. However, at hour 2, following administration of NOVA7, we can see that the thrombin generation time is reduced back to what is was roughly our control level, indicating reversal of fondaparinux effect. And then looking on the right-hand side at endogenous thrombin potential, we can see that fondaparinux abruptly reduced ETP, and then following administration of NOVO7, we can see restoration of endogenous thrombin potential. However, it's not quite to the level that we saw with our controls, indicating perhaps that there's only partial reversal of fondaparinux effect. And subsequent studies, when they evaluated this, saw, again, sort of mixed results, most of them steering towards incomplete reversal. The next strategy that was evaluated was use of PCCs, specifically activated PCC in FIBA, as well as an inactivated 4-factor PCC of Cascadil, which is not evaluated in the U.S. So patients in this case had plasma exposed to fondaparinux, and then were given one of the 3 treatment strategies that we see here. With the PCCs, theory in mind being that the factor 10 content and the activated factor 7 content of FIBA would again be able to overcome the factor 10 inhibition and drive forward that prothrombinase complex formation, leading to reversal of our indirect thrombin inhibition and fibrinolytic activity. So with this study, patients' plasma was titrated to 1.5 micrograms per milliliter to act as a simulated overdose. And we can see with fondaparinux that administration of it led to large increases in lag time, decreases in peak thrombin generation, as well as about a 50% reduction in endogenous thrombin potential. The first strategy that was evaluated, the recombinant factor 7, while it did show improvements in lag time, failed to demonstrate any benefit with regards to ETP or peak thrombin generation. So even at the 90 micrograms per kilogram dose that we saw studied earlier, there ultimately wasn't significant restoration. However, when looking at FIBA, the 20 units per kilogram dose, we see that lag time has been corrected, peak thrombin generation has improved, and that with ETP, it's now back to roughly what the control levels were. This would indicate a more comprehensive and more complete reversal of fondaparinux. And then with the third agent studied, the inactivated PCC, while we do see improvements in peak thrombin generation, we see a paradoxical lag time. And the authors theorized that this paradoxical lag time is due to the high heparin content contained in Cascadil, which is roughly about 10 times what we see with the other 4-factor PCC products. And when these patients' plasma was given a dilute protamine solution, they did see a correction of the heparin effect, leading to normalization of the lag times. So based off of the study, we see that PCCs are an efficacious option for reversal of fondaparinux. Here at UVA, we use Kcentra, a 4-factor inactivated PCC, as well as use it for reversal of the anti-10A anticoagulants, specifically the DOACs. So while Kcentra doesn't have the same heparin content that Cascadil does, it still does have some listed as an inactive ingredient. So at the doses that would potentially be administered for a bleed reversal, we can see that patients might be exposed to 200 units of heparin. And then looking at some of the data from confirmed HIT studies, we see that patients exposed to a flush range of 10 to 13,000 units did have development of HIT. So the 200 units that our patients are exposed to is within that range. And while a single dose of Kcentra doesn't necessarily line up with the mean duration of 8.1 days, patients that do have a history of HIT would potentially be at risk due to immediate re-challenge with heparin. And therefore, with the package, considering the package insert of Kcentra, it is contraindicated, leading us to choose one of our alternative products, so which would be consideration of NOVO7 with potential incomplete reversal, or administration of FIBA, which due to the activated factor 7 content in it, might have a greater thrombotic risk than Kcentra. And so this next question is just to really pose. So a 79-year-old female, 6 hours post hip surgery, receives fondaparinux for DVT prophylaxis. 10 hours later, her hemoglobin and blood pressure have declined, and the attending physician wants to administer factor VII. However, they don't believe that it will completely reverse the bleed and want to supplement it with another agent. Which agent should they consider using? So with this patient case, the patient received fondaparinux 6 hours after surgery. At 17 hours, with subsequent decreased hemodynamics and worsening anemia, the patient received 3 units of red blood. Over the next roughly 32 hours, the patient continued to bleed, anemia continued to worsen, they developed atrial fibrillation, and they still maintained a relatively high drain output rate at 75 milliliters per hour. And then at 39 hours, the decision was made to give another 3 units of blood and then to administer recombinant factor VII tranexamic acid at the trauma dose of 1 gram every 8 hours, and which saw a massive decrease in the drain output rate that was sustained for over 24 hours, and improvement in hemodynamics. So with fondaparinux, due to its high reliance on renal clearance, we can see that with poor renal function, there's increasing half-lives. The patient in this case had a half-life of 49, or a creatinine clearance of 49 milliliters per minute, leading to a half-life of 29 hours. Based off of 2 half-lives, we can see that with this patient, the expected duration of activity is going to be about 58 hours at minimum. And so with this extended duration of activity, there's a greater need to correct that the anticoagulation and antifibrinolytic activity. So in this case, the decision to supplement with tranexamic acid allowed them to act directly on that fibrinolytic activity and bypass the decreased TAFI activation caused by the indirect thrombin inhibition. So this subsequently led to decreased plasmin and improvement of the decreased fibrinolysis. And so it also allowed them to supplement the NOVA7 activity, which is happening upstream from our inhibition, our factor Xa inhibition. So by acting both above and below the inhibition, allowed for a more incomplete reversal compared to just NOVA7 alone. So overall, with fondaparinux, we do have 3 potential strategies. However, all 3 both have their own intrinsic flaws. And so based off of that, there is still need for better reversal agents. There's 2 main categories that are currently in development. The first is serum parentog, which is being used as more of a universal agent. And then there's ones based around antithrombin itself. But the main effect with both of these classes is that they would be able to reverse or inhibit all 3 of the anticoagulants we've talked about today. The first one, serum parentog, it's a highly cationic molecule which forms H-bonds and charge-charge interactions with the negative components of the drug molecule. Unlike protamine, which requires the large sulfate content of heparin, this one does not, allowing it to be a little more universal and applicable in nature. And based off of that universal status, it was able to receive fast track designation by the FDA in 2015. And unlike protamine, serum parentog so far has demonstrated a more mild side effect profile. Main side effects shown have been facial flushing and taste disturbances. And then it also doesn't show the prothrombotic effect that we've seen with our factor products. And so while serum parentog has been developed more on the DOAC side of things, the antithrombin agents have been developed specifically for reversal of the parental products. And so the goal with these agents is to have a competitive binding site for the antithrombin drugs that is devoid of anticoagulant activity, similar to how Praxbind works. And it provides a binding site for dabigatran, and then also doesn't cause any potential anticoagulation itself. So 2 main pathways, decreased anticoagulation or increased heparin affinity. The first option that was looked at was recombinant antithrombin. By inserting a proline residue between arginine 393 and serine 394, they were able to alter the conformation of the arginine, completely abolishing anticoagulant activity of the antithrombin. And then using a second point mutation by substituting glutamine for asparagine 135 and blocking N-glycosylation, they were able to increase the heparin affinity about threefold. However, with the recombinant antithrombin, there's significant production issues, which is why they looked at a second different version using chemical modification, specifically 2,3-butadiene treatment, which you all might be familiar with as it's one of the two main chemicals used in artificial butter flavor. And using the butadiene treatment, they were able to also modify arginine 393, leading to decreased anticoagulation activity. And through the purification step of the manufacturing process, they continually selected high heparin affinity forms, leading to even greater increases in heparin affinity than what we saw with the recombinant option. And so in vitro studies demonstrated efficacious reversal of all three antithrombin-based agents with both drugs, so both the recombinant antithrombin and the chemically modified. Looking at the in vivo studies that they performed with ATBD, the chemically modified version, we can see that mice that were randomized for fondaparinux reversal to ATBD or placebo had a reduction of roughly 86%, which is similar to the reduction seen with the recombinant form. And then for reversal of unfractionated heparin, we can see over here that ATBD performs similar to protamine, indicating that it was equally as efficacious for reversal. And so while they demonstrate equal efficacy to our current option of protamine, there's also an increased safety profile. And looking at the APTT assays that they conducted, we can see that on the left with protamine administration at high enough doses, we do see that paradoxical anticoagulant effect. And then we also see when heparin has been co-administered that protamine at high enough doses is able to reverse it, but then once you get too high or have a potential misdose, that you do see that the anticoagulant effect. With ATBD, there is no rise in APTT at any concentration, so you don't have to worry about the anticoagulant effect. So similar to Praxbind, where you have a high affinity for the drug molecule, you have complete abolishment of activity, allows for safer dosing with patients that need emergent reversal. And this brings us to assessment question number 3. A colleague asks you to explain why companies would be developing new reversal agents when protamine has been successfully used in practice for several decades. What benefits do the inactive antithrombin reversal agents have over protamine for the neutralization of heparin derivatives? Is it A, increased immunogenicity, B, ability to completely neutralize low molecular weight heparin and fondaparinux, C, greater paradoxical anticoagulant effect, or D, that it also works on direct oral anticoagulants? And in this, it is, just like the other questions, is also B, the ability to neutralize low molecular weight heparin and fondaparinux. So this was the antithrombin-based agents, so the ATBD as well as the recombinant one. They don't have any activity against the DOACs. So main takeaways from this presentation: the immunogenicity of protamine places patients at risk for developing several reactions, including thrombocytopenia. Over the last weekend, Jeff Sessler and I actually came across a potential protamine-induced thrombocytopenia patient where they had a large decrease in their platelet count about 2 to 3 days afterwards, and then after looking at the anesthesia record, we saw that they had received about 240 milligrams of protamine in the operating room. Protamine completely neutralizes unfractionated heparin, but it may only partially neutralize low molecular weight heparin. So again, that partial reversal of anti-10A activity leads to reduced efficacy for low molecular weight heparins. Selection of fondaparinux reversal strategies requires careful consideration of both patient and drug-specific factors, and then various universal reversal agents under development may offer safer and more effective options for the reversal of our parental anticoagulants. And what questions do you have?
So we don't follow PTTs for heparin here. So after giving protamine, should I check an anti-10A? Do I get one before I give protamine? Do I wait to give protamine till I get an anti-10A get back?
So while we do use anti-10A levels for monitoring heparin, you should still use the APTT. So the anti-10A provides a great level for the amount of drug that's currently in the body. However, studies have shown that after protamine administration, there was no relationship between the anti-10A level and potential to have continued bleeding. APTT shows the intrinsic pathway of the clotting cascade. And so while it's really just a surrogate marker for the heparin activity, it is going to show more the pharmacodynamic effect of the drug, of protamine's effect, rather than just simply pharmacokinetic, which you would see more with the anti-10A. And so while you don't need a baseline per se, because the situations in which you're giving it, you know the patient is bleeding or you're presuming that they're bleeding, the baseline really wouldn't alter how you would dose the patient, and it would only provide, again, sort of another confounding data point. So again, a baseline APTT, it could be prolonged due to heparin. It could also be prolonged due to the other conditions that I mentioned, APS, liver failure, or an underlying coagulopathy. So really just that single APTT after protamine administration is what you should be getting, and will provide you the data that you need without giving you any additional confusion.
So if you had to write a guideline for fondaparinux reversal, would you just say give everyone Nova 7 and TXA together, or would you just say just give one? How would you decide what to put in a guideline if you had to write one?
I would probably write that you could just give Nova 7 first, and then because of that duration of action of about 6 hours, and quick onset of action, you can see whether the Nova 7 is working. And whether it's working or not, you might add subsequent administration of tranexamic acid. In the guideline, I also might stipulate that consideration of patient-specific factors such as reduced renal function might warrant co-administration of the two together.
So in the past, I think that I've always learned to kind of avoid the combination of factor 7 and things like TXA and Amicard together, just because of the increased thrombotic risk. So are there any patient-specific factors or any kind of patients you would not want to give that combination to?
I would probably err away from giving that combination to patients with a recent cardiac history or recent cardiac events. And however, I think overall with tranexamic acid, the thrombotic potential with it is relatively low. And I think perhaps considering that into administering them separately rather than bringing on the thrombotic potential of both together might allow for a little safer drug utilization.
I haven't had to give protamine to any of my patients before, but when you look in EPIC, there's like a flat dose for either 25 or 50, and it looks like on one of your answers, you can dose it more specifically. For patients who are getting like over Lovenox 75 milligrams, would you recommend adjusting the rate of administration that's currently fixed in the order right now?
So it was low molecular weight. It was low molecular weight heparin.
And for protamine, like,
protamine.
because you specified that there was a rate adjustment, but in EPIC, like, it's a flat rate right now.
No, I mean I wouldn't adjust the flat rate in EPIC. So the 5 milligrams per minute is really just the maximum acceptable rate in which you could infuse it. So I would just stick with the flat one. There is no sort of specified minimum rate at which you should run it, but running it about 30% less than the max might allow for decrease adverse reactions.
But for somebody who's getting like a lot of, like, they're getting a higher dose therapeutic for like our more obese patients.
You're still capping the protamine dose at 50 milligrams.
Okay, got it.
Yeah.
That answers my question.